Hi, I'm Mauro Fradeani, and I would like to talk to you about phonetics. And especially, I would like to discuss with you the importance of S sound in prosthodontics. Actually, I would like to, first of all, define the closest speaking space, and then understand how the S sound can in some way determine or condition the vertical dimension that we found in our patient. More than that, we also discuss and describe the mandibular movements during the S sound and how could be very important in prosthetics. So let me start saying that the S sound, very important step, because the correct pronunciation of this sound that is determined by the uniform passage of a wide, flat band of air that is forced between the hard surfaces of maxillary and mandibular anterior teeth is really a very important step. Very important step for two main reasons. First of all, I would like to say that it's very important that while pronouncing the letter S, the maxillary and mandibular teeth, they actually reach their maximum level of contiguity and drawing close to each other but never coming into contact. So it is called the closest speaking space. So that's the maximum and contiguity of the teeth during this kind of pronunciation. So the use of S sound is the most practical method for determining clinically the acceptance of the vertical dimension that we have found it. Because excessive elevation is shown by a marked difficulty in pronouncing the S sound because the teeth completely invade the freeway space when the two arches come into contact. During the mock-up phase or the provisional phase, the clinicians is able at this point to test the patient adaptability because that is possible to see whether the patient is able to adapt in just a few days, in a couple of weeks, recreating the correct speaking space, at the same time improving, of course, the phonetics. If it is not the case, it means that doesn't happen, is not successfully achieved, the vertical dimension must be again maybe lowered until the emission of the correct sound is in some ways re-established. The congruity of the clinical situation that is created with the mock-up or with the provisional and then reproduced in the final work will be confirmed by favorable phonetic test results, which will confirm the adequacy of the dental-labial relationship that we have achieved. So vertical dimension is tested in this way. Very nice step in pros. But another important step in pros, very important, even maybe more important maybe, is the mandibular movement and tooth position. Because you have to remember that actually there is a considerable variation in mandibular movement during pronunciation of the letter S. So this aspect must be evaluated carefully before embarking any kind of rehabilitation of the anterior area. Why I'm saying that? Because in many cases, some patients keep the mandible in a retruded position, like normally the class 2 patient, and emit this specific sound by means of a vertical mandibular movement that forces air between the mandibular incisor crest and the palatal concavity of the maxillary incisors. Other, in contrast, protrude the mandible until you achieve the head-to-head position between the maxillary mandibular anterior teeth. This anteriorized movement is typically found normally according to Spear in class 3 patients, as well in a sizable percentage of class 1 cases. So it's very important to understand. And if you look the patient here, you can understand that this patient, for example, is classically have a vertical movement. So it's not coming in front, just vertically created. But the other side, this patient is protruding her mandible quite a lot. You can see also the last part is like in reality, that is horizontal movement. Very classically, in most of cases, in class 3 and class 1. So looking the patient move their lips during the S sound is very important, maybe by pronouncing Mississippi classically, or maybe counting from 60 to 69. It's very nice to understand. So in such patient that coming in front, any tooth lengthening, or even any slight buccal positioning of the mandibular teeth, or like lingualization of the maxillary teeth, may cause unwanted contact between the anterior teeth. And this, of course, will lead to incorrect prophonesis, creating an immediate sense of impaired diction for the patient. In contrast, if you have an excessive buccal palatal distance between the maxillary and mandibular teeth, creating a large space during the pronunciation of letter S is normally compensated by interposing the tongue, producing the typical lisping sound. And this sound is created by air passing between the hard surfaces of teeth and the softer surfaces of the tongue. So finally, when you do pros, please take care about what happened. Look before on the left side. I'm sorry for the not nice quality of the movie, but it's important to see how the example works well in this case. Look, the patient on the left side is going edge to edge, so almost touching the teeth, lower and upper anterior teeth. So in this way, you have to ask yourself, may I elongate the teeth if I need it? Like in this case, the teeth were long just 8 millimeters central incisor on the upper arch. We need to increase approximately 2-3 millimeters to really have a nice final outcome, like we have done, as you can see on the right side after the treatment. But look what happened after the treatment and after a period of adaptation of the patient. Neuromuscular adaptation takes place in this case because now we have just a vertical movement, no more the horizontal like before. Now, after the treatment, it's just vertical movement. That is the proof that in this case, we have the chance to really readapt the patient the proper way in order to achieve a successful result.